Um, Sir and ma'am, with your permission, can we start?
Yes, I think we should.
Okay, sir, we are like to start.
Can I start?
Yes, sir.
Okay. Good afternoon to you and welcome to this very special partnership meeting between the Indian Society of Gastroenterology and IJCP. This evening, we are going to discuss a very common problem. The problem of asthma and acid reflux. Two of these, both of them are independent, considered to be independent, but we now know that asthma and acid reflux often occur together. We don't know why. It is an observation that bronchial asthma makes reflux worse. It is also an observation that reflux makes bronchial asthma worse. In fact, bronchial asthma is now considered to be one of the extraesophageal manifestations of gastroesophageal reflux disease. So this seems to be a question of which came first, the chicken or the egg. So we are going to discuss this relationship between gastroesophageal reflux disease and asthma today. And we are going to answer a few questions. Can GERD or reflux cause asthma? Do these medications which are taken for asthma, including inhalers, make GERD worse? What is the link between acid reflux and pulmonary hypersensitivity and the causation of asthma? And then what is the impact that it is going to have on treatment? I'm aware that the audience would like us to keep the discussion quite basic, quite simple, and we are going to do precisely that. Now, to talk about this, we have a very special guest, Dr. Shobna Bhatia, who is the head neuromotility and consultant gastroenterology, one of the leading ladies in gastroenterology in the country. She did her advanced fellowship training in esophageal motility and PH at Philadelphia, USA. With more than 25 years of global experience in the field of gastroenterology, and in particular, gastroesophageal reflux and esophageal motility, I think she is the right person to tell us more about this connection between bronchial asthma and gastroesophageal reflux disease. Let me also tell you that Dr. Shobna Bhatia, who's a very, very senior gastroenterologist, a very reputed teaching gastroenterologist, was a recipient of the Unichem Lectureship in Gastroenterology and Indian Society of Gastroenterology Olympus Mitra Award for Endoscopy. Numerous awards. She has been on numerous forums and also a lot of task forces which go on to evolve guidelines in the Indian Society of Gastroenterology. So we have a person with a rich experience. And it is over to you, Dr. Shobna, for first the warm-up, I would say. Let us all listen from you about the relationship between bronchial asthma and gastroesophageal reflux disease. So it is over to you, Dr. Shobna Bhatia.
Thank you to the ISG and to the IJCP for asking me to talk on a topic that's quite dear to me. What I have decided is, along with my moderator, I would actually call him a colleague, we'll go into a discussion mode after, say, a 15-minute short talk. And thank you, Ramesh, for that lovely introduction. I suddenly felt, one, very old, because you put that tag of seniority on me. And of course, I felt very happy when you talked about my academic achievements. So 1 minute, I have to share my screen to show you some few slides which are here. So I hope they come on now. And 1 minute, I'll have to go full screen from here. Why is this happening? Just a moment. Yeah. So can you all see my screen? Ramesh, can you see my screen? Okay, thank you. Thank you, Ramesh.
Yeah.
So those just a few affiliations there. And just to say that I have no conflict of interest today. So what is the plan? I will talk just a few things about this. One is the prevalence, the effects of asthma on GERD and vice versa, a little bit of the mechanism of how this happens. The second is the diagnosis, and a little bit about the treatment. And then I think Ramesh and I will go into a discussion mode. So first few things. So we have GERD, which we know is, in lay terms, the best way to define it is presence of acid in the wrong place at the wrong time. That's the most simple way to describe it. And there is acid which is coming into the esophagus. It's not supposed to be there. It's coming in excessive amounts, and that's how people get symptoms of heartburn and regurgitation. But sometimes this acid may also, by virtue of having organs that are next to the esophagus, cause some damage. So let's say to the laryngopharynx, where it causes cough or chronic throat clearing. In the respiratory system, it's cough, sometimes going to pulmonary fibrosis, asthma, and what is important today also in our setups is that lung transplant rejection. The others, of course, like enamel erosion, are pretty rare, though dentists believe that any enamel erosion should be given the tag of gastroesophageal reflux. The others are otitis, sinusitis, etc., etc. We won't dwell on these much. So what is the prevalence? So in India, the prevalence of GERD, that means if you went house to house and asked people how frequently they have either heartburn or they have sour regurgitation, you'd find that 1 in 10 people have these symptoms at least once a week or twice a week, which is why we say that the average of prevalence in GERD in the population is about 10%. In contrast, if you take patients of asthma and you ask them how often do they get heartburn or do they need to take drugs for acidity, this range is between 30 to 90%, which is a very large number. The average is about 50%, where patients who have COPD, the prevalence is higher than in patients who have pure asthma. And the vice versa, if you look at patients who have asthma, the prevalence of GERD ranges between 19 to 78%, as we just discussed. Whereas if you go to the population and ask them how many have asthma, 1 in 5 people have some degree of respiratory symptoms, which may or may not be significant. Now, if you look at these two disorders, if GERD is prevalent in about 10% of the population, and asthma is prevalent in close to 20% of the population, then it is very easy to imagine that many of these people, subjects will have both together. However, these numbers are much higher than what is the original prevalence of the disease alone. And therefore, there is a possibility that these are linked for various reasons. However, cause and effect relationships between asthma and GERD do not seem to have any positive result. And therefore, so far, all we can say, we don't know what came first, the chicken or the egg. And whether there is a true cause is still not really proven. Just a moment. Okay. So what is the mechanism? In simplistic terms, if you think that suppose some degree of acid came up into the esophagus, came to the larynx, and then was aspirated into the lungs, anybody would get cough, they would start getting breathless. And this is what we say is a direct mechanism in which microaspiration is the problem. However, the more important theory is the reflex theory. And the reason I say this is that when we test for reflux, or when we ask patients whether they have more heartburn or they have more regurgitation, then even patients who have only heartburn and no regurgitation will also have asthma. It is easy to imagine that if a person had regurgitation, a small amount of that regurgitant fluid would get into the trachea and therefore cause cough. The second theory is the reflex theory. Now we know that both the esophagus and the tracheobronchial tree share vagal innervation. So whenever there is reflux in the esophagus, that means the esophagus is irritated by the acid, the neural mechanisms will also cause bronchoconstriction. And sometimes you see this in a person who, let's say, has a small amount of chilies. He's really not swallowed, he's not aspirated the chili, but many of them develop bronchospasm as soon as they eat some spicy food. And this explains that there is a reflex which is connecting the bronchial tree and the esophagus, which is why this gastroesophageal reflux can cause asthmatic problems. The other reason why this happens is the drug interactions. And it's very easy. You know that theophylline and beta agonists like salbutamol, which is the biggest example of beta agonist that we have, both these cause relaxation of the lower esophageal sphincter. When the lower esophageal sphincter relaxes, the acid from the stomach starts coming up. And therefore, the patient has reflux. Now, in some of these people, when the acid comes up, they may also have additional aspiration. And when they go to a respiratory specialist, the idea that the doctor would have is that patient's asthma is actually not got better, but has got worse after starting bronchodilators, and therefore the doses of bronchodilators are actually increased. On the other hand, if this patient is given PPI or a proton pump inhibitor, because this heartburn has come up after adding theophylline or a beta agonist, then in that case, there is a cross reaction between the PPI and the bronchodilators. So there are PPIs like say rabeprazole or esomeprazole, which react with theophylline, and therefore the serum concentrations of theophylline are actually pushed up. And here, then the side effects of theophylline, which is relaxation of the LES, come up. And quite often, even after giving the PPI, the patient keeps having a cough, which is similar to a cough of aspiration. After they eat, they have these cough spasms, and the larynx is absolutely irritated. So it's important to remember that it's not only the disease, but the treatment that you use for each of these diseases can also cause an interaction. This is especially true for theophylline. So when do we suspect that this asthma is not pure asthma? That means it's not allergic, it's not chronic bronchitis, but that is an additional element of reflux here. So in children, quite often, they will come with recurrent aspiration pneumonia. So especially children who have a tracheoesophageal fistula, who have developmental anomalies, or those who have a large hiatus hernia, are the ones who come up with recurrent aspiration pneumonia. As far as the asthma is concerned, just taking a beautiful history, most of the asthmas which are seasonal and classic asthmas start in childhood, and there is usually a history of atopy in them. In asthma which is related to GERD, it is late onset, usually starts in the third, fourth decade. It's usually nocturnal because patients who have more reflux and regurgitation tend to have microaspiration at night when they lie down. The other thing is that this asthma is usually non-seasonal and does not worsen in the seasons when most people asthmatics would have worsening of symptoms, like when there is a lot of pollen, a change in weather, like in the rains, etc. Second is that many of these patients will say that they had some degree of mild heartburn before the asthma started. And that tells us that possibly there is an association here. If asthma is worsened by meals, immediately after eating a heavy meal, which is containing a lot of fat, then these people get worse. The other thing is in a supine position, as I mentioned earlier. Asthma is worsened by bronchodilators because the bronchodilators would decrease the LES pressure and fluid would come back. And associated cough, laryngitis, or repeated pneumonias. And last, which is again a contentious issue, is that the patient should respond to the anti-GR treatment. But quite often, the response is not as expected. I would expect some degree of response, but quite often the asthma may worsen after a PPI started. So this is again revising the types of extraesophageal syndrome. And then we come to what do we do about this? So how do we diagnose reflux in patients with either asthma or atypical symptoms? Now, first of all, we must remember that this initial diagnosis is based only on symptoms. And as we normally do, for all symptoms of reflux, we don't jump to doing any kind of endoscopy or any kind of Phmetry. We first give a treatment of a PPI. Now, treatment with PPI in GERD is usually you can give a single dose, say, of pantoprazole, or if the GERD is bad, we can step up to, say, esomeprazole or rabeprazole. The same policy is used for when we are treating GERD and asthma. You give 4 to 6 weeks of a PPI, which is optimized. And if the patient continues to have symptoms, then only do we do an upper GI endoscopy. Now, endoscopy, as expected, is normal in more than 50%. And again, if you find esophagitis, it does not establish that this reflux damage is related to the asthma. No, it just tells you that there is reflux damage. The other one is the pH monitoring, and I'll just come to that in a minute. Okay, so pH monitoring, we put in a small tube through the nose for 24 hours and look at what is happening to the pH. I'll be showing you some pictures after this. And as I said, the first thing was to give a PPI challenge, which has been tried in many studies in the past. The only thing to say this, that sometimes patients may require up to 6 months of treatment, but at 6 weeks, we must take a call and decide whether this patient needs further investigation. So just looking at the temporal association, before we go on to the investigations. So if you take a cough reflux and you take a reflux cough, so the first group that is here on the left is the patients who have reflux first and cough later, just 11 patients. And on the other side, you have cough first and reflux later. That means they have heartburn as well as cough. And you find that in only 30%, that is out of these two, you get them simultaneously. Mostly it is either the patient has only reflux on Phmetry, and then you find that the patient coughs. On the other side, the patient will cough and then have reflux. So this is what a Phmetry would look like. Okay, sorry. A Phmetry would look like, what you see here on the left is that the patient has a reflux. Can you all appreciate this, Ramesh? Ramesh?
Yeah. I
Okay.
can.
You can, okay. So,
but then you probably, for the benefit of the audience, you'll probably have to explain.
Yeah, I'm just explaining that. I'm just explaining this. So when we put in a catheter through the nose, we would have multiple channels, and channels are of two types. One is pH, which measures the acid, and the other one is which measures the flow. So these multicolored things, except for two, one is the orange line in the center. Unfortunately, I don't know how to get my one. Just a moment. Let me get my no. Ramesh, do you know how to get the pointer? No. Ramesh? Ramesh?
Yeah.
Let me get the pointer on this.
No, I can see your pointer. You're moving it around.
Oh, this mouse is seen. Okay, then it's fine.
Yeah,
it
is seen. It is seen.
Okay, sometimes the mouse doesn't get seen. So
no, it is seen.
Okay, fine. So the mouse is disappearing here. That's a problem.
Okay, when you go in for slideshow, it disappears.
Yeah, so that's what I'm trying to see if I can. If anyone knows, can you all help me?
Right click on, no, go to slideshow mode.
Okay.
Go to slideshow mode. Right click now.
No, it's going to the next slide. No, not working. Okay, I'll show it with my whatever we can explain. Or otherwise, I'll escape this for this particular slide.
Yeah. Okay? I think that's good. That
is a good idea. So now if you look at this carefully, I know it's not clear because we are not in the slideshow mode. So all these lines are actually telling you about the flow of the bolus. And this one is the pH. So you see that this patient first, at least a few seconds before, maybe 30 seconds before, has a reflux episode. This is the flow which is going backwards. That means it's arising from the LES and then going backwards. And out here, you also see that the pH has gone down, which means this is the time that the patient has the reflux. But for about 30 seconds, there's nothing happening. 30 seconds later, you find that the patient has a series of cough. On the other hand, you can have a person who has cough and has reflux at the same time. This is actually more convincing as an episode that this reflux is causing the cough. In this one, it is not so sure. But on the second side, definitely it's convincing that this is the cough episode because these probes are in the stomach. And the moment the patient coughs, you get these kind of images. So this is the pH which is going down. This is the reflux going backwards. And this is the cough. So this is just to show what an impedance pH can tell us. Okay. So this is, again, an old slide, sorry. So we did one study many years ago. And we took these patients and looked at their respiratory symptoms. And we found that in patients with asthma, especially those who are difficult to treat, the prevalence of symptoms was 70%, and esophagitis was in 40%. Now, this is higher than what you would find in the general population. However, this was a very select group of patients who were difficult to treat. And after giving them omeprazole 40 milligrams per day, what improved was their respiratory score as well as the FEV1. So that was important, that we proved that we actually improved the symptoms as well as the respiratory parameters. So when do we investigate these patients? As I said, it's only after a course of treatment, when there is treatment failure. And the last, and not to forget, is prove that there is reflux prior to sending a asthma patient for GERD surgery. In the last 4 or 5 years, there are many studies telling us that in patients with difficult to treat asthma who have GERD, where you have proven that there is GERD, about 60% of them will benefit not only for their GERD, but also for the asthma from just doing a fundoplication. So therefore, this is to be kept in mind. It's not so common to do it in patients with ordinary reflux, but we would definitely do it if there was a patient who had a large hiatal hernia and lot of volume reflux, and also when GERD is causing the asthma as well. So PPI I mentioned. PPI you usually need to give double the dose. And unless if you give only single dose, many of these PPIs will not work. So the drugs to give are usually rabeprazole, esomeprazole, and if the patient doesn't have cough as a side effect, continue these. From there, we can step down to say dexlansoprazole. But pantoprazole is something that is weak, but if patients are responding to it, that's fine. Coming to prokinetics, it's important to know that prokinetics do nothing to the esophageal motility. All the prokinetics that we know are only going to increase the gastric empty. So if the patient has volume reflux, like there is more of regurgitation, then in that case, you give a prokinetic and give them as individual doses twice or thrice a day, rather than clubbing them with the PPI once a day. So what are the recommendations? And these recommendations are from the American Gastroenterology Association for looking at how a gastroenterologist can be involved, or when you should call a gastroenterologist when a patient has asthma. So before the patient is sent to the gastroenterologist, please make sure that the pulmonary or the ENT for ENT problems is seen, and the investigations that are required are done by them before it is labeled that the person has gastroesophageal reflux related problems. The patient should receive aggressive acid suppression, which means twice a day PPI for at least 6 to 8 weeks, and look at the focus on response before we start testing them. Importantly, no single test can identify reflux as the etiology for extraesophageal symptoms. Besides the Phmetry that I showed you, laryngopharyngeal reflux can also be tested by putting a pharyngeal probe in the upper esophagus, but that's a very inconvenient test and is still not available very often in India. So you look at the holistic picture, look at the patient presentation, the diagnostic results, and also the response to therapy before doing anything. Now, testing for Phmetry. Something that I didn't mention during Phmetry is how should we do it? Should we ask the patient to continue the PPI or stop the PPI? Now, if the patient is responding, at least partially, or the patient has previous esophagitis, then in that case, therapy should be with the PPI to see why the patient is not responding, even though the patient is on optimal doses of PPI. However, if the patient has not responded at all, and we suspect that this patient does not have reflux, then stop all the drugs and all the PPI drugs, and then do the reflux testing. Now, the most important statement in this talk is if the patient is not responding, 2 ppis, and the testing shows that the pH testing is normal, then reflux is not likely to be a contributing etiology for the asthma. In that case, we should look for other causes. And therefore, in such patients, we should be very careful before sending them for any kind of invasive therapy like surgery or endotherapy for reflux. In any case, surgery should be considered only if there is a large hiatus hernia and there is significant proof that this patient has a lot of reflux. And the patient has to be told very clearly that even though we are doing the fundoplication for reflux, it is possible that your reflux is not related to your asthma, and nothing may happen to your asthma after the reflux is treated. So the patient has to be warned about this. Otherwise, they will feel by reading some literature that the treatment is going to cure their asthma as well. We should warn them about this. Okay, that's the short talk that I had to give, and give you a small algorithm here. So if you suspect extraesophageal reflux, give the patient PPI first for 6 to 8 weeks. If the symptoms persist, then the first thing is look at the weight. The weight also needs to be brought down because excess weight is also one of the causes of both asthma as well as GERD. If the patient has improvement in symptoms, then in that case, there's nothing more to be done. Just titrate to the lowest dose of acid suppression and let the patient continue as he is. There is no point in going for further investigations if the patient has responded to treatment. Thank you. So, Ramesh.
Yeah, thank you very much. I think it is a very simple and elegant description, very practical, and I think a lot of take-home points. I think the most important thing which I remember you mentioned is that figure of 30 to 90%, and
Yes.
approximately 50% of asthmatics would be having gastroesophageal reflux disorder. The second important thing is you mentioned about the very important role that the PPI trial has to play in the algorithm of approach to a patient who's got troublesome asthma, not responding adequately. Also patients where you have reflux and chest symptoms where you're investigating. The third important point that you did mention is that there are soft indicators in asthmatics which would suggest that reflux is playing a role.
Yes.
One of them you mentioned is that when they become worse with bronchodilators, it means probably that reflux is a problem. When they have hoarseness of voice and they have other reflux symptoms, a dry hacking cough, these are all important symptoms, soft indicators. And finally, of course, you did mention that we should not jump into fundoplication as a treatment because, people are frustrated. The patients are quite frustrated. The asthma is becoming worse. Also, reflux is a major problem. So then they start scouting around, and some of them would be recommended fundoplication. Okay, why don't you go for that? In the absence of a hiatus hernia, fundoplication is actually a very risky surgery because patient may end up with no response and probably be worse off after the surgery. I think 4 or 5 important points that you made. Now let us take up the case scenarios. Four case scenarios. It's not. It is just that for the benefit of the audience, I thought we'll discuss these situations. The first case is a 40-year-old male. He's quite obese. He's working in the corporate. So obviously, he's sort of always throughout the day, he's sitting in front of the computer. He has troublesome reflux for which he takes PPIs on and off. He feels better, but he starts coming with nocturnal cough and breathlessness, and he starts, he says that he's waking up at night with this particular symptom. Now, he has been investigated only basically. So in such a situation, a person like this coming to the general practitioner, what would you expect the general practitioner, what would be your advice to the general practitioner? What should be the prescription by the general practitioner for this patient?
So first of all, I'll try and revise my internal medicine here. So this is a person who's an executive, intermittent heartburn, and nocturnal cough. Is that what you said?
Nocturnal symptoms.
Nocturnal cough or GERD symptoms. So the first thing is, if there is nocturnal cough, also see whether this patient has some kind of a postnasal drip. That's something we should not forget. You know, when we do these specialty talks and we get into super specialization, we quite often forget simple things. So first is find out whether this patient has any sinusitis and he's getting some postnasal drip because of this. The other thing is, if a person is having nocturnal symptoms, the first is to ask them what time they have dinner. In all cases of gastroesophageal reflux, especially those who have a hiatal hernia, we suggest that the patient should have an early dinner, or at least keep a gap of minimum 2 hours before going to lie down to sleep. I mean, even lying down is not good, bending is not good. So this would be the first thing to tell the patient. And if the patient has this heartburn, well, starting a PPI once a day is no harm, because eventually gastroesophageal reflux is something that has to be handled at the primary level. If all the patients start coming to secondary and tertiary levels for simple heartburn or nocturnal regurgitation, I think we won't have anything else to do.
Very true, very true, very true. So I think basically, the important message is, even at this stage, the advice should be on sound basics.
Yes.
About the basic lifestyle management, weight reduction, and the medications,
Yes.
rather than this patient being referred to higher center.
Absolutely.
I think a lot of it can be taken care of at the basic. Okay. My next question is, of course, we always think that the ENT people nowadays have got this habit of palming off patients to the gastroenterologist when they get tired of seeing a particular patient with a refractory cough or dry cough or whatever, and they say it's a gastroenterology problem. This is thing, you go to the gastroenterologist. Now, it is a difficult situation even for the gastroenterologist. You mentioned some soft indicators that a particular ENT problem or a pulmonary problem could be because of reflux. Are there any other soft indicators or anything on examination that we can do to sort of suspect that reflux could be playing a role?
So if during endoscopy you find that there is a posterior ariditinitis or there are laryngeal nodules, that is something that can tell us that there's probably reflux related damage. Now, coming to the treatment, I mean, everybody is so fond of PPIs and they prescribe it and co-prescribe it for every patient, thinking that everybody has a reflux related problem. And of course, the other thing I hear from them is that we give them so many medications, and these medications can also cause some gastritis. So we give this to cover the gastritis, which is fair, I think. But what happens is the patient then begins to think that he's got this reflux, which is responsible for the cough. And when the cough is not going away, they keep chasing the gastroenterologist rather than going back to the primary team. So if the patient has cough after food, cough after lying down, especially when the food is coming up, those are indicators that this patient has a reflux related problems. But in other cases, it is purely an ENT problem. And that's something that they should be handling it themselves. Now, if you look at the response of cough to PPIs, if you take patients who are Phmetry negative, that means if you systematically did the Phmetry in all these patients, which is not practical by any ground, if you do the Phmetry, then those who are positive for Phmetry, also only 20 to 30% will respond so well that the patient becomes asymptomatic. In the rest of them, there's definitely an ENT cause that is found.
Yes, very true. I think it has to be managed as a partnership between the ENT specialist and the gastroenterologist.
Absolutely.
A question that has come up is, you did refer to that prokinetics may not have a very major role to play. Is it?
Yes, correct.
So the question that has come up is the use of prokinetics, because obviously the person is referring to combination therapies which are so commonly available. What stage of the treatment would you add on prokinetics? Do you start with a combination of PPI and prokinetics from the very beginning, or do you work with PPIs alone for some time and then use prokinetics only in certain situations, if at all? What are those situations?
So first of all, prokinetics, I do not use them in combination. I would use them at individual drugs. And the reason is that the prokinetics that are required for reflux, so we'll discuss only reflux, they are required at the time when the meal is taken. So the prokinetics should be taken just before the meal, and they assist in gastric emptying. So the original idea of long-term effect of long effect prokinetics, or what do you call them? Yeah, so those basically it started with Perinom. And it's mainly in pregnant women who have nausea throughout the day. Ramesh?
Yeah.
Yeah, I thought we'd lost you.
I'm here, but I cannot see your video is frozen.
No. From my side, your video looks frozen.
That's a strange.
So there's a network problem. Okay. So
Yeah.
basically, what happens is if you take a long-acting prokinetic like Perinom, that's used in pregnancy because the patient has nausea throughout the day. In patients with reflux, you need the prokinetic at the time that the stomach is emptying, and giving it over the full day really is not of much benefit. So I prefer to give it as twice a day or thrice a day, depending on the symptoms. The second, the place where I use the prokinetics, one is in people who have volume reflux. That means after the PPI controls the acid, the person continues to have regurgitation. So regurgitation when they lie down, regurgitation when they bend down, or just simple regurgitation 2 hours after a meal is the best place where we need the prokinetics. Also, patients who are found to have a hiatus hernia will benefit from the prokinetics. The last group where I use the prokinetics is patients who complain of bloat after a meal. Now, these are people who may have some degree of delayed gastric emptying, and prokinetics can actually correct that. And these are patients who are usually diabetic or have some other form of gastric emptying disorders. And that is why prokinetics are required. So these are the few sets where I would definitely use a prokinetic. Otherwise, I'll make do with the PPI and wait and watch as to what's happening.
Okay.
Ramesh, I cannot see you or hear you.
Can you hear me?
Yes, I can hear you now.
Yeah.
But I think your video is frozen. That's fine.
That's okay. There is this concept of esophageal hypersensitivity and pulmonary or bronchial reactivity.
Yes.
Do these things go parallel to each other, or is one responsible for the other, or is it just that the acid goes into the lungs and causes the problem?
So if you look at esophageal hypersensitivity as a concept, here the patients do not have significant acid coming up. But even the smallest amount of acid that comes up gives rise to symptoms, which means it is still a form first of gastroesophageal reflux disease. And probably these people have hyperalgesia, and therefore they are extremely sensitive. They're hypersensitive to anything that comes. And this bronchial sensitivity is probably part of that. Now, which comes first, I'm not sure.
Now, children, children with asthma, you mentioned that it is unlikely that reflux would be causing a major problem. But we've heard that small children, infants with reflux also can have severe asthmatic problems. How do you explain this dichotomy?
So when you look at asthma as a primary disease, asthma has many phenotypes. So if you look at the classic asthma, that means seasonal, responding well to bronchodilators, that particular phenotype usually starts in childhood. But in very small children, or rather babies, they seem to have reflux right till they are 1 or 1.5 years old. And these are children where when they outgrow this reflux usually, and these are children who may land up with having pneumonias and coughs, but they usually don't manifest asthma. This is because of microaspiration. Ramesh, we've lost you. Yeah, you come back.
So now the main question, of course, is that the medications that are used for bronchial asthma, we know that they can make reflux worse.
Yes.
Among the medications, are there some that spare the lower esophageal sphincter and are probably could be preferred in patients who have got gastroesophageal reflux?
So all the bronchodilators, which are inhalers, all inhalers spare the lower esophageal sphincter. All the beta agonists as well as theophylline, if they are taken orally, salbutamol oral or theophylline or derifylline orally, will cause LES to relax. However, the newer class of drugs, that is the ipratropium bromide or the tavatropium bromide, they are the ones that do not affect the lower esophageal sphincter, and they are also available mainly as inhalers. It's important to know that in patients who have asthma, if the patient has so Ramesh, you're back. Ramesh, are you co-host again?
Yes.
Problem. I'm sorry, there is some internet issue.
Some problem. Yeah.
Yeah, there is some problem. Correct.
Okay.
So if you take drugs like ipratropium bromide or the tiotropium bromide, they are usually available as inhalers and they do not affect the LES at all. So all inhalers can be taken safely. However, in patients who have asthma, very commonly they have small or distal bronchial disease. These diseases do not respond well only to bronchial inhalers, because the inhalers do not reach the smaller bronchi. And for anything to reach the smaller bronchi, we have to give a systemic treatment, which is usually a theophylline derivative. And that is why many people have to take the derifylline, and the asthma and the GERD complex is going to continue in them. Ritu, we have lost Dr. Ramesh again.
Yes, ma'am.
Yes, so is there anything that we can do?
Yeah, he joined.
He's back. So Ramesh? Yes, Ramesh? Ramesh?
Yeah, I'm here.
Yeah, I think
There is a problem with our Wi-Fi connectivity here.
okay.
Anyway, so now if we look at the four situations, we have discussed about a patient with gastroesophageal reflux disease, a disorder, hiatus hernia, nocturnal wheeze, how should we approach? We've also discussed the fact that a patient who is an asthmatic, who is stable for a long period of time, because of the onset of reflux, the asthma could get worse, in which case we need the patient to manage the reflux and send the patient for further management if he is a non-responder. We've also discussed a situation where asthmatics who are on medications, they become worse. They Dr. Shobna.
Yes, I can hear you and see you. Yes.
So we've discussed all these situations, and I think I was actually going through the question box. The question box, we've answered 4 or 5 questions that have come into the question box. Now, does this hold true even for alkaline reflux? Is it only for acid reflux? Can alkaline reflux also cause similar problems?
Absolutely, because alkaline reflux is usually bile. Now, bile causes the same irritation of the esophagus, and it has been shown that once in a while, a small amount of bile salts can actually get to the upper esophagus if the patient has significant reflux. But this is not as common in the routine population. It may happen in a patient who has undergone some kind of gastric surgeries that the bile finds its way back into the esophagus. Otherwise, in more than 90% of the cases, the reflux that you're going to see is from acid alone. Now, for management of this bile, the usual thing that we give is sucralfate because it can bind the bile and therefore the symptoms can decrease. But otherwise, the management remains the same.
Yes. So what would be your final closing remarks as far as this conundrum is concerned, asthma and reflux, take-home messages for the audience?
So a few quick take-home messages. First is that both asthma as well as reflux are common in the general population. And therefore, it's quite possible that a person just by chance has these two together. However, if the patient who has asthma for the first time presenting in adulthood, having heartburn before or even after the asthma or cough develops, there is a chance that this person has both reflux as well as asthma. And in this case, the management of reflux remains like you would manage any other patient with reflux. That means you would put them on a PPI, but the PPI has to be a double dose. That means you give it at least twice a day. Try it for 6 weeks. If the asthma also doesn't change, intensity doesn't change, then in that case, we start investigating. We do not investigate unless we give a PPI trial. If the PPI trial is successful, then we don't need any further treatment. The patient receives his treatment for asthma from the respiratory person, and you continue your PPIs. The second group of patients is those who are not responding. Now, when they are not responding, we have two options. Either they actually have reflux or they don't have reflux. And the only way to break this impasse is to go and do investigations. Endoscopy is easily available everywhere. If there is evidence of esophagitis, you know that there is reflux. No evidence of esophagitis. If the patient is going to be planned for surgery, go for further investigations like Phmetry. If the patient is not going to be planned for surgery, we can still counsel the patient and let the treatments continue. I'm not in favor of unnecessary PPIs, but if a patient doesn't have a large hiatus hernia, the patient has minimum symptoms, I think treatment can be continued. However, if the patient is still not responding, only then do you go and do further investigations. In a patient with a large hiatus hernia, if the patient is going to go for surgery, we have to do all the investigations. Otherwise, we will be going on a wrong track. The last bit, which I didn't talk about much, is patients with lung transplant. Patients who are undergoing lung transplant have to be investigated for gastroesophageal reflux, because if they have reflux, it has to be optimally managed before the transplant, because one of the causes of rejection is continuing acid reflux. So those are the few take-home messages. Dr. Ramesh?
So I think thanks a lot, Dr. Shobna, for having kept the whole discussion very simple and very easy to understand. Now we understand this complex relationship between asthma and reflux. And I think it's important for all of us clinicians to believe that a lot of them can be managed with basic clinical sense and the basic modalities. And very few of them would need a higher treatment at a higher center. Thank you very much, Dr. Shobna. I think we've come to the end of the hour, and it has been an absolute pleasure to be interacting with you about the complex interplay of asthma versus reflux. With this, it's over to the organizers.
Thank you, Dr. Ramesh.